webinars are made possible thanks to generous donor support. If you'd like to contribute, please visit our website, autism.org.
Hello, my name is Dr. Steve Edelson, and I'm the Executive Director of the Autism Research Institute, or ARI, in San Diego, California. This webinar today is sponsored by ARI and the World Autism Organization. Now, let me first say a few words about the Autism Research Institute. ARI was founded by a pioneering researcher and parent advocate, Dr. Bernard Bremlein, in 1967, and this is our 56th year of monitoring, supporting, and conducting research. More specifically, ARI funds research studies, sponsors an international support group network with over 250 group members, as well as a science network. We sponsor think tank meetings, publish original articles and books, produce videos and webinars, and a lot more. You can learn more about ARI at www.autism.org. I also want to say a few words about the World Autism Organization. Their overall mission is to improve public policy and practices worldwide regarding education, health, welfare, rehabilitation, employment, and recreation. They do this mostly by promoting and coordinating technical and material assistance. The World Autism Organization also encourages the exchange of information among all organizations. Now, let me introduce to you our speaker today. Dr. Federico Balzola holds board certification in gastroenterology and digestive endoscopy at the Modena University School of Medicine in Italy. And he attended medical school at the Turin University School of Medicine. Dr. Balzola has numerous scientific publications in international medical journals, and he's presented his research at several international meetings, including one sponsored by the Autism Research Institute. Dr. Balzola practices at several clinical research settings in Italy and focuses primarily on assessment and treatment of GI issues in autism. His treatment plans include both dietetic and pharmaceutical approaches. So you please join me in welcoming Dr. Federico Balzola. Thank you.
Hi, Steve.
Hi.
Thank you for your introduction. And thanks to invite me to talk to your meeting. The topic that I'm dealing with is gastrointestinal symptoms in autistic patients. And this is my hospital in Italy, in Turin, where I work. And this is Turin. I really invite you sometimes to come to see our very nice city. So coming back to gastrointestinal symptoms in autism, I think we have to go back to the some of disease origin. When Hippocrates had the perception to say that all the disease begins in the gut, he was right. Because more recently, with a lot of enthusiasm, the Human Genome Project in 1999 aimed to discover the origin of all the diseases. Because we thought that genetic predisposition and exposure to an environment trigger were both necessary to develop an inflammatory or autoimmune disease. So we thought that one gene, one protein, one disease. But unfortunately, this very enthusiastic way to understand the human diseases was a little bit not true, because a lot of epidemiological study showed an increasing of chronic inflammatory and autoimmune disease with a decreasing of the rate of infectious disease. As you can see in this slide, a lot of infective disease like mumps, hepatitis, tuberculosis were decreasing in the last 50 years, while we saw a dramatic increase on Crohn's disease, multiple sclerosis, asthma, and diabetes, so all inflammatory and autoimmune disease. For this reason, even allergic diseases were more common, and the incidence of pediatric inflammatory bowel disease, you see, is going up as well. Even all the allergic disease in all the Western countries were all increasing. So all these data were a little bit against the idea that the pathogenesis of every disease has a genetic background only. So we can say that we may be predisposed, but we are not born or destined to develop chronic inflammatory diseases. On the other side, the increase of many inflammatory diseases in the last 4 decades in the Western Hemisphere put again the role of the bowel in the entire pathogenetic pathway of many diseases. Especially Dr. Alessio Fasano said that the bowel is a battlefield where enemy and friend negotiate molecular trafficking, leading to either tolerance or immune response. Because we have to think that the largest interface between our body and the outside world is the intestine, 9 meters of length and 200 meters square. And Fasano said that what happens in the intestine don't stay in the bowel. If we see, this is a mouse slice of the intestine is covered and protected by a single layer of endothelial cells that you can see here in red. If you have an ulcer, a small injury, you can imagine all these B cells, T cells, and dendritic cells are all immunocells, how much they are recruited here in a way to protect the invasion of many bacteria or some toxins that they come from the intestine. But on the other side, you have to think that all these B cells and T cells through the blood vessel can go around in all our body. And so all the things that happen here is true. They go away from the intestine. They can interact with many, many organs. So if we think this way to how we can scale this inflammation or impact of the inflammation in all the body, you can imagine that here, if it is the layer of the intestine, this is the mucus, and many injuring can happen here, but it's a physiological way. The problem is the degree of this kind of the injuring, that they can activate the pro-inflammatory allergic cytokines, break the tolerance, and then act in a chronic inflammation or allergy. So it's a problem of number and amount of things that they can pass through the endothelial cells to the reduced protection that you can have on your bowel layer. This is important because if you think that celiac disease is even an autoimmune disease with a genetic background, you can see how in all this year the incidence of the celiac disease is growing up. That means that it's not only a problem of a genetic background, but is even a problem of the environment. Let me go again. Autism is another increasing disease. You can see how many patients are now affected by autism. We say in 2008, 1 out of 59 patients. One every 37 male, sorry, 1 every 37 male and 1 every 151 female. So this is a huge number. So this is another disease that's growing up as all the other chronic inflammatory diseases. And in this study of the London School of Economics, if we think that the incidence of autistic patients grow up 35-fold since 1960, you can imagine the impact that this disease can have on the social cost. And this study of the London School of Economics found how the social cost of the autism is over than the cost of cancer, heart disease, and other stroke heart disease combined. That means that we have to do everything we can to face this incredible increasing disease, and not only for the patient, but even for the impact that it has on the social cost. So the role of the intestinal permeability has to be again seen, because when you have an augmented intestinal permeability, that means that something changed or something caused this changing of absorption. So what can cause root absorption abnormalities? The zonulin release, the zonulin as a protein, is the first component of the tight junction. Tight junctions is the small space that there is between two endothelial cells. And zonulin was discovered by Dr. Alessio Fasano in 1993, and is one of the family of proteins like occludin, claudins, are all molecules able to make the intestine more permeable, able to permit the passage of many substances, regulate the paracellular trafficking pathway from the bowel to the blood vessel. And zonulin gene is on chromosome 16, an important chromosome that has been implicated in many autoimmune disease, in cancer, and disease of the nervous system. And you can see how zonulin levels augmented has been implicated in many diseases like autism, celiac disease, IBD, but even in metabolic disease like diabetes or obesity. So it means that many of these new inflammatory disease has been related to a changing of the intestinal permeability. In this slide, you can see how the level of zonulin has been found augmented compared to the normal control. And for that, we have to think to go back to the origin, to evaluate the environmental changing on human evolution. Zonulin is a mutation that happened 2 million years ago of a previous protein called haptoglobin 1. And this mutation happened just in humans and not in all the other apes. And the action of zonulin on the tight junction permitted a more rapid communication between the environment, that means what I eat, where I live, and the immune system. And probably was one of the most important steps from human evolution compared to the apes. And when you think about your bathroom, where your bathroom tiles are connected with the cement, one each other, and the cement was previously thought waterproof, unable to permit the passage of any substances or any things. Now we know that zonulin permits to modulate this pace here, permitting the passage of the substances that are important and necessary for our body. And if you think that our intestine is so huge, like a tennis court, you can imagine the impact if something doesn't work perfectly, or if it doesn't work in their normal way, or if zonulin works too much, and so how many things can pass through the epithelial cells of the bowel and creating a big damage far away from the intestine. For this reason, the paracellular pathway that comes from the action of the tight junction can be summarized that in this way, tight junction are a dark horse implicated in host and of disease states ranging from acute injury to chronic inflammation and autoimmune disease. So coming back to our lifestyle evolution, you see millions of years ago, in the last 50 years, how many changing happened. Changing that positive because they permit you to talk with you far away from the United States, but means even a fast environmental change of the bowel trafficking. That means, again, a change in bowel immune homeostasis that was stable for millions of years. I mean, this very rapid change found and prepared our immune system. And so the life state changing for many decades probably can be summarized in 3 different aspects. First of all, the diet, and then the amount of food that we normally eat, the hygiene, the pollution, and drugs and antibiotics. All these things have an important impact on bowel trafficking and consequent bowel environment. And for this reason, the pathological increase of intestinal permeability cause the inflammatory chronic disease. And if we think the human evolution where here we were hunter, used to eat fruits, nuts, tubers, and occasionally meat, in the last 10,000 years, we changed from nomadic and we settled in a lifestyle, and the advent of the agriculture and the animal farms permitted to change our number of group of people and prepare village, found city, and the evolution that we have in the last 400 of generation. That is a not very big mountain number. And imagine even the grains, how it was in the past, how was different the harvest and the way to cultivate grains, and how the food industry now play an important role promoting food everywhere in any moment at any time that we can consume. So these changing are all in the last 50 years, because 10,000 years ago we were able to eat, but the condition of eating, the presence of infective disease, the war, and any other kind of possibility to die very young were present, not like now. And if you think that gliadin is part of gluten that exert a lot of different action, like the innate immunity, the permeating effect, chemiotaxis, adaptive immunity, probably gluten is not a poison, but is a problem when we introduce a big or large amount of gluten in our bowel all together. This is was even found in the study of the Magistris that was published years ago, where was found how autistic patient had an increased intestinal permeability compared to the healthy controls. So patients with the autism and intestinal permeability augmented were put under gluten casein-free diet. And in fact, after the diet, their altered intestinal permeability decreased a lot. What is important to see that even the normal control that they had a normal intestinal permeability, when they were put under a gluten casein-free diet, even them they decreased the rate of the intestinal permeability. That means that not only in patient with autism or patient with other disease, the diet can interfere with the absorption and the permeability of your intestine, but even in healthy individuals. So this can say that how our intestine is dynamic and can change its action even in a healthy state. And so the food that we all know, anti-inflammatory food, but even junk food or food able to give inflammation, like many food that we normally eat every day, has to be put in a way how they change, how they can interact with the intestinal permeability, how they can exert an inflammatory action. You see on the left in this slide how if I having a high fiber diet, my mucus layer is very thick, and the prevalent bacteria that they stay in my mucus are Prevotella. But if I change my diet, if I'm eating more gluten, a lot of gluten, if I drink a lot of milk, bovine milk, and if I have a high fat diet, immediately the mucus layer decrease in terminal of thickness, and the bacteria that they stay are completely different and increase the paracellular permeability of my intestine. So inflammation, decreases in insulin sensitivity, autoimmunity, like on the other side, all the anti-inflammatory action of the Prevotella was present. And this effect has been published many years ago, saying how the food was able to induce neuroinflammation, the effect of gluten, casomorphin, and gluteomorphin. And if we go back on the hygiene hypothesis, where in the past people were used to stay all together in small houses, and all the bacteria and the viruses were passing in different age very, very quickly. So our immune system was used to face a lot of the bacteria and a lot of viruses at any age. We come here at the modern time where all is clean, all is tidy up, and the reduction of bacteria exposure at any age of our children is a big changing. A changing that doesn't permit the immune system of the child to be used to face a lot of different kind of virus or different kind of bacteria. So here the immune system become intolerant, where here with all these things, the immune system was much more tolerant to infection, to the dirty things, and to food. And how it was eating at the time. Imagine the hygiene here, drinking milk, and now that we have all the processed food here. As well, how it was difficult to drink clean water, and how now with all the soft drinks and all the water in our refrigerator, it's possible to have clean drinks. And the global increase in antibiotic consumption is another big problem, not only for the resistance of many bacteria that we have here in the hospital, but even for the damage that the antibiotic use has done on the bacteria in our intestine. And a little thing was also be said about the pollution and the exposure to many heavy metals, because now there are consistent number of papers that correlate pollution and heavy metal and the early exposure on the neurodevelopmental disorder. That means that we have something that we still not know perfectly, but is another thing that impact on the immune system and the bacteria on our intestine. So for this reason, we have to go back to our microbiota. Microbiota is an organ made by all the bacteria that we have in our intestine. Its weight is 100 kilograms. The microbiota has 10 times our human cells, 150 our DNA. And bacteria after bacteria are able to surround 2.5 times the earth. So you can imagine the amount of impact that this organ have on many aspects, or our metabolism, or producing of vitamins, but even on immune system. And if we see the rural urban population, you can see if I live in a country area and I eating different food, I have a Prevotella kind of bacteria prevalence. While if I'm staying in the city eating a certain kind of food, the bifidobacteria are the bacteria prevalent. These are pro-inflammatory and anti-inflammatory kind of bacteria. So this can even give you the idea in how just where I live, I can change my homeostasis is in my bowel. And the old term of dysbiosis that we can summarize in both in body with the loss of a balance between pathogenic or protective bacteria. This was the dysbiosis term that was made by this guy many years ago. Now we have to change the idea of dysbiosis. We have different level of dysbiosis, different degrees of dysbiosis able to induce different degrees of inflammation. We can think dysbiosis like our glycemia that has different rate, and different rate means pathologic diabetes, intolerance to glucose, or normal value. This is something that we still don't know, and we do have to perform studies to distinguish the different grade in the way to understand better all the possible diseases that this dysbiosis can induce. Now, there are many papers published that they show how the capacity of the dysbiosis to induce inflammation and immune response. So this is something that we can't say, I don't know that. It's something that is written, it's something that's published, it's something that we have to know all the time we face or we treat an inflammatory disease. Because the microbiota, the gut microbiota, is implicating a huge number of disease, allergy, liver disease, fibromyalgia, aging, diabetes, pancreatitis, spondylitis, and even in autism and many hepatic encephalopathy. That means that the bacteria interact even with an organ that for a long time was considered outside the rest of the bowel. And in this work on the ankylosing spondylitis, that is a sort of inflammatory disease of the bone and the nerves, they found a specific dysbiosis able to upregulate zonulin release. So we have the second step. Not only dysbiosis can induce augmented permeability, but we found a specific dysbiosis able to upregulate the zonulin release. And the conclusion is that zonulin is a trigger on inflammation, an important trigger of inflammation. So when in the past we know that zonulin was increased but in gluten, we can say now not only gluten, but also diet, dysbiosis, and bacteria overgrowth. They can increase the zonulin release, increase the intestinal permeability, and develop a chronic inflammatory disease. So now it's crucial in our evolution to study these diseases that are very far away from the bowel. And brain is one of this kind of disease. Because if we go back to autism, the epidemics of autism and schizophrenia as a part of trend of not infecting chronic disease has to be considered all the time. I have a patient with autism and schizophrenia. Because if we check the microbiota pattern in patients with autism compared to healthy controls, in this slide, the microbiota of the autistic patient is in red, in green, in healthy control. You can see how the pattern of the microbiota is in a certain way. And so it means that all the patient can be considered with in important dysbiosis. But now we have a lot of possibility to treat the dysbiosis, not only the probiotics that were available many years ago, but even now that we have many psychobiotics. There are bacteria able to interact directly with the central nervous systems. Many paper has published the results of the role and the results of the role of probiotics in autistic patients. But what is now emerging is how the microbiota transfer therapy is able to change the dysbiosis, and especially in autistic patients, to improve the gastrointestinal symptoms and the behavioral symptoms. This is the first study that has been published in 2017 on 22 patients, showing an increasing of the amelioration of the behavioral aspect of this patient, and was done on just 1 year of follow-up. Then the long-term benefit has been shown in the second part of the study, so the long-term benefit of the microbiota transfer in reducing in the long term all the symptoms, the gastrointestinal symptoms that were present before to start with this kind of therapy. So the future aspect of the fecal microbiota transplant has been shown in many papers, and the future of this approach can be thinking in many inflammatory, autoimmune, and degenerative chronic disease. And if these aspects are not dealing just with autism, but even obesity, ulcerative colitis, many other inflammatory bowel disease, you see how the drug company are interested in this new therapy. They are preparing new way to give this big amount of bacteria to the patients. But in many inflammatory bowel disease, in autism, in chronic hepatitis, in solid tumor, inflammatory bowel disease. That means that many drug companies are open their space, trying to find the right drug, the right way to administer bacteria in many different inflammatory disease. So I think we have to go back to autism, because now the literature indicates that autism patient might early categorize in inflammatory patients or not inflammatory autistic patient. This is crucial because if we do that at the very beginning of the diagnosis, we are able to interfere, and reduce the inflammatory action that start very beginning at the onset of the autistic disease. Because the immunocell, the pro-inflammatory immunocell, has been found in patients with autism. Cytokines that were present more in autistic patients than in the control. Here again, patients with autism showed less anti-inflammatory cytokines, but even the behavioral of the patients in the study shown how the autistic patient have a worse behavioral aspect. Irritability, hyperactivity, you see, was much more present when the group of autistic patient, had gastrointestinal symptoms. This means that inflammation has been found in patients with autism, but even the behavioral aspect are worse if they suffer for intestinal symptoms. Because the intestinal symptoms has been published with a wide range from 9 to 91% of patients with autism showed intestinal symptoms. That's a very high rate. That means that a lot of patients have intestinal symptoms, and sometimes, or too often, it's difficult to understand their presence. But even Crohn's disease or ulcerative colitis has been found more present in patients with autism than patients without autism. That means that not only inflammation, but even classic inflammatory bowel disease like Crohn's or ulcerative colitis are present in this kind of patients. So some speculation has to be done, because many patients that were enrolled in the study checking the amount of intestinal symptoms were patients with the pain threshold elevated. Autistic patient very often has this threshold very high. And we have also to say that patients with autism are nonverbal, and so the communication of the problem is very, very often present. And a lot of times they show the symptoms more with the behavior than with crying. But it grows up the concept of possible correlation between pain and pain able to induce autistic behavior. This is a milestone, because for the first time it was possible to think that even intestinal symptoms were able to interfere with the behavior of the autistic patient. When we think about a child pain, we think this position is the classic when you have pain and try to reduce the discomfort. But even this frog, is he relaxing? Is he having tummy ache? Is the hand of this frog protecting the tummy? Well, when we face the patient with the autism, we have to think that their behavior is a way to communicate. And all these positions are positions that we call antalgic position, because they provoke a pressure on the tummy and a way to reduce the pain. When you have a stomach distension like this patient, if you perform an X-ray, you can see how distended is the stomach. If I have the same stomach now where I couldn't talk with you, that means that they are able to support the disease, to support the pain, and are not able to communicate the disease, because probably they are growing up with this condition and they think that it's normal to have these symptoms. Even when they have constipated, when they are constipated, they try to go to poo. All these positions are positions that they perform to improve the possibility to the feces to pass through the rectum, are all positions that we advise the patient with constipation, saying, when you are constipated, try to reduce the angle at 45 degrees to improve more strength in the evacuation. So this is what we say to the patient. And the position that the patient that I showed to you before, they were able to do by themselves without any teaching. And even when you see the autostimulation, this stimulation is a way to press the rectum or the gallbladder to the rectum. And if you perform an X-ray in this patient, you can see how many feces are stored in the rectum. So the discomfort of the storage of the feces and the pain that the rectum distended can provoke to you, ask you to have certain behavior. again, when I have a sleep disturbance or I bumped in my head, probably the reflux is one of the reasons, because esophagitis is very common in these patients. And achalasia, that is an evolution of the chronic untreated inflammation, make the impossibility for many food or liquid to pass through the esophagus to the stomach, making many times the selection of the food of this patient very, very frequent. But look at this homework of this little girl when she has pain. This is a homework, this young autistic patient that consider the pain that she normally have normal. But when she has more pain, look how her homework become completely different, and how is able to express more her pain because she was not crying, changing, doing the homework than the normal way we normally express our pain. And even malabsorption of the tummy of this patient is not normal, is pathologic. And even the feces of this patient that were found with a lot of starch or a lot of lipids are not normal. And even the failure to breathe is one of the aspects of many, many autistic patients. So, with a lot of support of many group, even the Autism Research Institute of San Diego permitted us to change our knowledge on autistic patients with gastrointestinal symptoms, and instead to go through and following this animal in this direction, we decide to go in the other direction, discovering the zebra instead of the hide of this patient, of these animals. And so we collaborate with our neuropsychiatric institution, and we start to study the patient, and the Dietary support was really, really important to do the first part of our study. From 2002, we followed 1,650 patients with gastrointestinal symptoms. These data are updated to 2020, are now to be published. So I just presenting the one where we have all this number and the kind of percentage made. So 39 autistic patients were selected for major gastrointestinal symptoms. 83% were male, 17% female. The mean age were 9 years, with a range from 2 to 45 years of age. The family history, these patients have the family history for autoimmune or inflammatory disease or IBS in the 35% of patients. The cesarean delivery or complicated pregnancy were present in 63% of patients. Feeding or weaning complication was present in 82%. Early use of antibiotic was present in 41% of patients. Acute event in the first year of age were present in 38% of patients. A behavioral disturbance emerging after gastrointestinal symptoms, you see, was in the 88%. So at first, gastrointestinal symptoms appears, and then the autistic symptoms. Constipation was present in 48%, diarrhea in 40%, abdominal pain 75%, macroscopic malabsorption in 46%, 24% hyperproctalgia or tenesmus, food selectivity or hyperexia was present in 20%, reflux or dysphagia in 35%. The laboratory examination showed how fecal to blood test positivity was present in 1/3 of patients, calprotectin protein in 41% of patients, and serological screening for celiac disease was negative in 89%, almost all the patients. Intestinal sonography, the ultrasound, found on lymphadenitis in 28%, thickness of the terminal ileum of the colon just in the 9%. But a lot of patients had a sort of fluid between the intestinal loops, meaning a sort of adenomesenteritis, an inflammation of the serosa that cover all the intestine. All these patients underwent the lower and upper endoscopy with biopsies. We found with the biopsy, because the gastroscopy and the colonoscopy, they did not show a lot of classic aspect of the inflammatory bowel disease. But the biopsies permitted us to find an esophagitis in the 51% of patients, eosinophilic gastritis in 4% of patients, a lymphocytic gastritis in 3% of patients, a duodenal atrophy in less than 1%, but we found MASH1 and MASH2 inflammation in this patient, the 43% of patients. MASH1 and MASH2 is not a celiac condition, but is a condition that make the small bowel very permeable and make a sort of malabsorption of many food. The ileum show a pathological lymphoid nodular hyperplasia in the 66% of patients. A chronic inflammation with eosinophils excess in the biopsy was present in the 93%. So almost patients showed an infiltration of these eosinophils in a pathological way that's over 40 HPF. Active inflammation was present in the colon, the 46% of patients, and the rectum had abnormal architectural granular aspects that are related to inflammation in the 85% of patients. So the eosinophils infiltration that you can see here in the slides of the biopsy was present nearly in all the patients, confirming the presence of the eosinophilic colitis in this patient. We confirm the previous published data that were published by Howard, Rent, and Christmas years before. What is important that the inflammation were probably pan-intestinal, because it was present in the colon, but even in the duodenum, even in the esophagus. That means that when the eosinophils attach the bowel, they do it in all the length of the intestinal bowel. So we decided to treat this patient. We tried to treat with the diet, the food maps diet, in a diet that excludes all the sugar that can interact with the microbiota, and reduce the milk and reduce in part gluten. And we give pharmacological therapy according to histological and site of the inflammation. And the result that we had are an important reduction of the constipation, an important reduction of the abdominal pain, the presence, the reduction of proctalgia and tenesmo in all the patient studies. But what was important, the neuropsychiatric aspects improved as well. In fact, hyperactivity was reduced, motor skill was augmented, the mental attention increased, and the imitation increased as well in a significant aspect. And in the long term, even the symptoms that were present in this patient reduced during the follow-up of over 1 year. We published this data, and we conclude that a significant association was present between clinical manifestation of this patient and the histological alteration. of this patient. That means that the inflammation induces the gastrointestinal disease, but even the behavioral aspect of these patients. So the role or the interaction between microbiota and neurological development has to be seen under the fog of my town. This is Turin, these are our mountains. Because for pediatricians now, they are very concerned about the first 1,000 of days of the children, because in these first 1,000 of days, I can interfere on my clinical inflammatory destiny. There are many aspects that can interact with the microbiota. They are able to imbalance the microbiota development, inducing an increased risk of inflammatory disease in children early in the life. You see that microbiota influence the postnatal immune system development in this paper published. As well, many aspects, many risks present in the conceptional moment, the prenatal moment, the birth, and the peri and early postnatal are all a lot of risks that can not be the cause of a disease, but they can augment the risk of develop the inflammatory condition. And if you see even the delivery mode, if I have a cesarean delivery, the bacteria that I can find in the bowel of the child are more the skin bacteria of the mother, and not the bowel bacteria that they know are much more the vaginal or intestinal bacteria. They are normal, they are present in the normal delivery. Even the impact of human milk on fecal on intestinal microbiota has been shown in many published papers. That means that even the natural milk exert a real protective action on the microbiota. So microbiota is a very fragile organ at the very beginning. It's like a child, and many steps can interfere with its good growing and consequently on the immune system and brain development in a very early phase of the life. You see here the pollution, environmental aspects, smokes, then the cesarean delivery, the formula feeding for the child, and then all the inflammatory aspect that the child can face during his early moment of the life. In this complicated algorithm, we can see how the prenatal and perinatal and postnatal aspect are all able to translate the microbiota. The microbiota translate all the environmental trigger in genetically susceptible individuals. So the microbiota is the results of the sum of every single risk. And second, the dysbiosis that then I can have with the zonulin increased permeability permit a loss of the barrier function. And this can lead to begin a chronic, non-infective, inflammatory bowel disease. All these aspects can have different degrees. It can come very early in the very early part of the life, or can be then able to appear many years after. So it's very complicated to understand when they can interfere or can be seen in all the inflammatory disease that can happen during the year. But it's crucial to think that all the major risks can act their action on an organ like the brain that is in development in a very early phase of the life, that's not protected anymore by the tummy of the mother, and in the first 18 months exert all the possibility to be damaged and then not anymore recuperate. So in conclusion, I can say that the gastrointestinal symptoms are present in a high percentage of ASD patients, and are very often present before the onset of the neuropsychiatric disease. A specific inflammatory disease different than Crohn's disease or ulcerative colitis with the eosinophil infiltration was present in the colon in more than 80% of our patients investigated. The dietetic and pharmacological treatment of the intestinal disease showed a reduction of the gastrointestinal symptoms and an improvement on the behavioral aspect of the autistic patients. Then the role of dysbiosis on the onset of this inflammatory process through zonulin release played a crucial role in autistic patients. And consider the central nervous system as an involvement and as a possible complication of an intestinal inflammatory disease. Consider autism like a multi-organ inflammatory disease, and the evolution from the descriptive understanding of the microbiota to a prospective longitudinal approach to predicting inflammatory or degenerative disease is now necessary. So it's necessary to perform the microbiota studies not in the group of disease, but following every single patient from the birth to the 3-4 years of age, in the way to immediately find if any pro-inflammatory dysbiosis is growing up. Then microbiota in its transfer to the intestine could be an important therapeutic tool in many inflammatory and autoimmune disease, autism included. And consider the importance of gastrointestinal symptoms in patients with higher threshold of pain with the absence of verbal communication. As I said before, patients that are able to communicate more with the behavior, they pain, than the crying. And consider the opinion of parents and their effort to better understand this complex disease. And at the end, consider the patient with autism like every other patient. This seems very simple, but is not. Many times these patients were not visited. They are considered too difficult to be managed, and so a lot of time they were put in apart. They are forgotten. And coming back to the environmental trigger, and as I told you, were food, amount of food, drugs, pollution, antibiotic, and even lifestyle, are all subclinical conditions able to interfere in the first 18-20 months of life, the intestinal permeability, and consequently my risk of chronic inflammatory diseases in the short or long term of my life. Because the subclinic presence of dysbiosis is really important, because patients consider normal after an immune trigger or an infective trigger can develop inflammation. We know this now after the COVID infection, how many patients consider with a normal immune system become autoimmune patients. And this is not because of the virus, but because they were in a sort of patient with an asymptomatic dysbiosis, where the environment in a rapid way changed their the possibility of the immune system to become inflammatory or to induce autoimmune disease. So at the very end, we have to go back to visit the patient, listen to the parents, and start to think about all the correlation that we can see and that the patient can do. So we don't need only blood tests or other tests that are available in this kind of patient, but we have to think, to watch, and to and face this disease from another perspective. Probably the old way to follow patient were the right way, because we were more able to distinguish the symptoms compared to now, where we are all based on the blood test results. And the last message is all these nice things that we publish, we are in literature, they are present in many, many topics of many, many meetings, has to go back not only in the literature, but they have to go on at the bedside of the patient, in the way to not be isolated like this bear, and to permit to all this new information to prevent all the inflammatory disease, in the way to reduce all the damage that the inflammation can do if the inflammation starts in a very early age of the patients. And in conclusion, I say that all the novelty or all the truth pass through three stages, as Schopenhauer said many years ago. First, it is ridiculed. Second, it is violently opposed. And third, it's accepted as being self-evident. This is our hospital, our city. This is my colleague, Dr. Carlo Alessandra, that he works with me on autistic patient, where we have a clinic and where we see patients all around Italy and all around Europe when they discover that a clinic that deal with all the intestinal aspect. So this is my real conclusion. I'm really thank you for your attention. Many thanks.
All right, well, thank you. We have a lot of questions. I can read some questions to you.
Yeah.
Okay. The first
yes.
one is about polyethylene glycol. In the US, we call that Miralax. It's often prescribed for patients with autism and constipation. Do you have any insight about how that influences the microbiota and dysbiosis?
Not yet. Not yet. There are many studies because it's something that interferes with the microbiota. But we have also to think that if the patient is constipated, it's much better to reduce the constipation than to think the interference of the drug to the microbiota. Here in Europe, you use much more the macrogol. That is something that doesn't damage the microbiota. But the second step is not to say, is the drug influencing too much the microbiota? Why this patient is constipated? This is the reason and the thing we have to do to discover if there is an inflammation underneath, something that can reduce the intestinal mobility. And then the constipation is the last part of the symptoms. So again, this patient has to be seen very, very carefully. And I think that before to give just a symptomatic drugs that like a laxative, we have to perform examination to visit the patient, exclude any fecaloma, for example, in the rectum, something that a lot of time has never been seen, and the patient has a pseudo diarrhea. It seems a patient that has a diarrhea, but it's not a diarrhea, it's a pseudo diarrhea. So again, this patient need to be studied when they have symptoms. I'm not saying that all the patient with autism has gastrointestinal symptoms, but the patient who have symptoms has to be considered like you and like me. If I have a constipation, I don't perform, first of all, the microbiota evaluation. I go to the doctor, I try the drug, I try the reason of my constipation.
All right. So in the presentation, you talked about a younger cohort that was in the study.
Yeah.
One person is asking, I'm 65 years old and on the spectrum. Do dietary recommendations make a difference for somebody like me in reducing GI symptoms and neuropsychiatric issues?
Yeah. Yeah, there are many papers I showed to you how the diet influence the microbiota and so the inflammation. But even if you travel, if I'm coming United States, my microbiota change because it is very dynamic. The point is which kind of food. This is a big problem. As I told at the conclusion, we probably need to be studied single. I mean, my microbiota is different than yours, is different when I'm there, is different if I'm touring, is different if I am 3 years of age, is different if I am 18. So the future needs to follow our changing of microbiota and to select that when will be possible, because I'm talking about something where we are in a prehistorical age. We have just seen the galaxia. We have seen the way where to go, but we don't have the shuttle or the way to go in another galaxia. That means that we have to be very, very careful. We know the problem, and the interaction food is very rapid, but it's very different between different patients. So the 16 patients that made the question, I can tell that probably you are the best one able to understand which is the food that you can take or you can suffer. Medical doctor has to stay on this side and make the study to better understand if the food maps diet or the gluten-free diet or the low in histamine diet is the best, or probably when you are 16, the diet, the role of the diet has to be postponed, because at 16 years of age, probably the drug, the pharmacological treatment is much more important than the diet compared to the very young people.
There are quite a few questions about microbiota transfer. Yeah. So one question is just about how that is processed. Where do they source it? Where does it come from? And how would you know that you're getting proper treatment?
Again, I'm sorry to say that now we are just able to analyze the 80-85% of our microbiota. We are now able to distinguish different kinds of bacteria. Bacteria are more prevalent or less prevalent. The treatment, the future treatment will be the one able to complete the part of bacteria that are not available. That's because we don't have so far the way to put in the right place of the bowel the right kind of bacteria. On the other side, the fecal transplant, the transplant of bacteria in the bowel represent a very simple way, but a very difficult way in terms of administration, but even a very dangerous way if it's not performed by doctor with patient studied in a very scientific way. Because now is the way like veterinarians use for cow. When a cow has diarrhea, they use the feces of a cow that has no diarrhea, and they put the feces directly in the bowel. That means that this is something that in the animal is possible, not in humans, where fecal is a transplant, and so has to follow all the rules of all the transplants. That means that we are open a pot where inside is a huge universe of information. We need to know our genome. We need to know our microbiota. We need a support of computer and artificial intelligence able to combine all this information that now are too many for our mind to be managed. So in a simple way, trying to answer the question, we have to wait more information. The only thing that we know now is that the diet and certain drugs are able to interfere on the microbiota, but these need to be studied in a very, very deeper way.
All right. Well, we have time for just a couple more questions.
Yes.
This question is actually about using nutritional intervention, which relates to some of what you spoke about. So how effective are just natural prebiotics such as leeks, onions, garlic, this sort of thing? Have you seen any research on that, or do you have any insight about it?
Oh, that's a good question. You open another world, because all the prebiotics are nutrients for certain kind of bacteria. And so it's true, many of these can interact with the right presence of good bacteria. Many fat, many that, for example, the butyrate is something that we can find in many food, and something able to act a prebiotic action, but even a lot of vegetables, as you mentioned before. But again, we are going talking something that is really easy to feel. If I'm going to that restaurant, if I ate something, I say, oh God, oh goodness, my stomach is suffering the food. So we are very able to relate immediately what we eat with something wrong in our body. But imagine how many passages there are between the food in your mouth, in your stomach, in your bowel, and then all the passage from the digestion and the absorption of the food, and then the interaction with the immune system. Probably when you have something wrong after dinner at the restaurant is because you had something 1 week before or 1 month before, but you never, you are not able to remember, but is the real reason of this change. That means that is a universe that now we know we have to study, a universe that now we know we have to go through, even to give answer to patients that they said what I'm having to eat, what I'm having to reduce, especially in the Western country, you're like mine, where all the food are processed. If you want to find garlic, which garlic are you going to find? The one in powder, the one that come in already inside the food. So it's really complicated. The real garlic is impossible to find. So we can also say that it's difficult to go back to the past. We have to go in front, trying to avoid the defect or the side effects of food, and trying to find the right effects or the food available. Hi, Steve.
Oh, hi. Yeah, well, I want to thank you for your excellent talk. I learned a great deal. I think after this, we'll be uploading this video to YouTube, and I'm sure it'll be very popular. And I'm thrilled that the grant we gave you, almost 2 decades ago, had made a big difference in your line of research. So that's very nice to hear.
Okay.
Yeah. Okay, well, I want to thank you again for your presentation, and let's keep in touch.
Absolutely.
Quite a bit we need to accomplish over the next, who knows, 5, 10, 20 years from now. And I'd like to thank everyone who attended this webinar. The Autism Research Institute sponsors quite a few webinars, 2, sometimes 3 a month. You can go to our website, www.autism.org, to learn more about our webinars. But thank you again.
Okay.
I'll keep in touch.
Be in touch. Bye, Steve.
Okay, great.
Bye.
Okay, bye then.
Bye.